Hello, it's my pleasure to introduce Dr. Zakia Khan. She is a co-organizing secretary of WCC 2023, a very famous interventional cardiologist at Fortis, Mumbai. Welcome you, ma'am, to WCC 2023. And first of all, congratulations for organizing such a mega event. Yesterday, we had a very splendid day with a lot of academic activities. So kindly tell us, ma'am, about your, how many efforts and how this WCC this year was different from the previous WCC.
I think this was one of the few physical meetings that we had from the past few years, and very nicely organized with a very good scientific content.
Okay. And this year you have tried to have make it an international platform of South Pacific, of Asia Pacific region. A lot of international faculties is also here, and you discussed about instant restenosis. Just tell us briefly about your presentation.
So basically, when we treat coronary artery disease, one of the prime treatment for blockages is angioplasty.
Yeah.
So once you have done an angioplasty with a drug-eluting stent, there is a chance that 5 to 10% will re-stenose in the coronary artery, in the stent itself, generally around the edges. So how to treat such patients? That was my talk.
Right.
And my talk focused more on how to optimally treat it and what is the data currently available and what's the new armamentarium that we have in treating such patients, because it's different from a routine atherosclerotic block. It's a combination of fibrous tissue, calcium, neoatherosclerosis.
Yeah.
And at times you need to understand why a stent restenos.
Okay.
So there could be some mechanical factors like, your previous stent was undersized, whether it under expanded, there was some stent fracture, or there was some patient related factors like, diabetes, one of the commonest cause of restenosis. Patients having osteal lesions have high incidence of restenosis. Long lesions, patients with graft treatment. So these are some of the subsets that restenose. So how to treat them? The current armamentarium that we have is imaging.
Yeah.
So if you image, especially with optical coherence tomography, you are able to understand not only the mechanical causes, but very nicely understand the biology of it. So whether there is a fibrous tissue, whether it's atherosclerosis, neoatherosclerosis, what is the degree of calcium, how bad is the plaque. So by understanding the mechanics and the biology of it, we can actually treat them optimally.
Right.
So if it's a fibrous tissue, better to cut it with a cutting balloon. If it's a neoatherosclerosis, probably, and if it's going beyond, maybe you need a new stent. Yeah. And if it's calcium, you need a calcium modifying agent depending on the severity of calcium.
Okay.
So if you optimally treat them, the chances of them coming back again will be reduced, although 2 layers of stent in a patient definitely will cause more chances of restenosis. We also have newer modalities like brachytherapy, laser to treat such patients.
Okay. So thank you for enriching so many factors that contribute to the restenosis. Just from the curiosity's sake, many of the patients post-stenting, do you recommend any kind of the screening as a routine screening so that they know about the stent status and they don't lend into the restenosis?
So the most important thing following stent therapy is compliance to the DAPT and the statin therapy. So if you are not compliant to therapy, you are likely to definitely restenose.
Okay.
At the same time, we do yearly monitoring by stress echo, by stress test, and of course, educate our patient to recognize the symptoms early. If they regularly walk, exercise, they will be able to pick up the early angina.
Yeah.
If it is there. So basically, symptom could guide you, or just a routine screening by stress echo would help you to understand them better. I do more of stress echoes rather than stress tests.
That on yearly basis.
Yeah, on a yearly.
And one more thing is you told us about the calcium lowering agents. What kind of calcium lowering agents?
No, calcium cutting agents.
Calcium cutting. Okay, fine.
So if the lesion is heavily calcified, then you do use newer technology. If it's a deep calcium, you use IVL. If it's a superficial calcium, you can use normal NC balloons, you can use cutting balloon or high pressure balloons.
Okay. And for the restenosis patients, what is the change in the therapy in the form of antiplatelet therapy? Is there any specific guidelines to have particular antiplatelets, like we need to have double for longer duration of time?
So
Dual
basically,
antiplates?
dual antiplatelet, even with restenosis, the guideline still says take for a year. But I select out my cases, if I have used a longer stent, maybe I would take it longer.
Okay.
And if the patient is tolerating the DAPT well, I tend to continue it for a longer period.
Right.
But at any instance, if the patient developing anemia, having any incidence of bleeding, then you can reduce your DAPT.
I just want to ask some medical question also, like because many of the times we are giving dual antiplatelets and there is always a lot of patients are on PPI therapies also.
Yeah.
So do you see for this interaction of the PPI with the antiplatelets, because both of them have cytochrome dependent metabolism?
Yeah, especially if clopidogrel
Yeah.
does have interaction with PPIs basically, and its effect could be negated or increased in depending on how many such drugs the patient is on.
Okay.
So I generally tell my patient not to take PPI if they are not having any symptoms,
Yeah.
but to take it on SOS basis.
Right.
There are people who write,
Who keep on taking for a longer time.
They keep on taking for a longer
just like
time.
routine their meals.
Yeah,
and,
so it hampers absorption of lot of things.
Yeah.
Not only drugs, then even your B12 gets very
Yeah.
low. At times, gastric mucosa becomes atrophied.
Yeah. So these are the small things which also should be taken care of apart from the interventional aspects. Thank you so much, ma'am. We had a very wonderful day yesterday, and we hope to have another spectacular day today also. Thank
Yeah.
you so much, ma'am.
Thank you.